Moving to the next talk, we're going to have Dr. Michael Dake, Ricardo Yamada, talking about balloon and angioplasty in the SFA.
Morning. Thanks, Marcel, for the introduction. Thanks for all the organization for this kind of invitation to be part of this program. I think this is a very challenging topic nowadays, especially because we have all those fancy devices, including stents and atherectomy. But I think especially we are in 2014, and this is also a very interesting topic because we are celebrating 50 years of the angioplasty. So this was the original paper published by Charles Dotter in 1964 when the technique was described. So I think it's of course a time for celebration, but it's also a time for reflection. And here comes this question: so what has changed since then? What has changed since Charles Dotter came up with his sequential dilators to treat arterial stenosis? So I think technology-wise, a lot has changed. We've passed through the non-compliant PVC balloons. We now have our modern and non-compliant and very resistant balloons. We also have cutting balloons, we have cryoplasty, and more recently we have drug-eluting balloons. So there's no doubt that technology has improved a lot. So, but what about the clinical outcomes of balloon angioplasty? So, according to Task 2 guideline published in 2007, type A lesion is the most appropriate lesion to be treated by angioplasty. This should be a single, like a focal lesion of the SFA, usually less than 5 centimeters. And interesting, this was quite the same type of lesion that was treated by Charles Dotter 50 years ago. So I know that can be a little bit frustrating. We would like to have better outcomes, but I still think that balloon angioplasty can play a very important role in the management of peripheral arterial disease. And here are some of the reasons for that. First of all, as has been extensively discussed this morning, I think cost is a big issue here, and we need to keep in mind that angioplasty is the cheapest endovascular option that we have available. And in times when cost is in the middle of every single medical discussion, we need to keep that in mind. So the second reason to consider angioplasty is, although it has been proved that for more complex lesions, angioplasty may not be the best option, and surgery is the most appropriate one, there is a subgroup of patients that do respond well to angioplasty, and this is an example that we'd like to share with you. So it's a patient that was referred to us, and as you can see, it's a multi-level disease, including occlusion. We put this patient like a task C lesion. More appropriate to be dealt with surgery, but the patient did not want to go to surgery, and then we decided to do angioplasty on him. So this is the completion angiogram. We were satisfied with the results, and then we decided to stop there and see how the patient would do. And then we kept following this patient in clinic for almost 2 years, every six months. And then the patient did pretty well, and finally, after almost 2 years, the patient came back with recurrent symptoms, and then we decided to do that angiogram, and we saw that recurrent lesion. So bottom line is the patient remained asymptomatic and free from target lesion revascularization for almost 2 years, which is a pretty nice result after angioplasty alone, even compare with all other technologies that we have available. So I think it's not a bad idea, it's a pretty reasonable approach to wait and see how some of those patients do after angioplasty, especially if they have a nice initial result. And in doing so, I think we can buy the patient some time, and also we can save us some tool for the future. We know that regardless of what we do for those patients, they will come back to us sooner or later, and when they come back, we want to have something else to offer them. So here comes the other reason to keep angioplasty in mind. So all the studies that compare PTA and stenting, those were the primary endpoints that were utilized. Primary patency rate, late lumen loss, and freedom from target lesion revascularization. I think there's no doubt that when those endpoints were used, the difference between stenting and PTA was pretty much significant, and so they're favoring stents. And in fact, for a lot of the studies, that difference was quite huge, and maybe even as huge as the difference between showed that picture. So, but when it comes to quality of life, as was also was discussed here this morning, there are some studies showing that there are similar results between PTA and stenting when quality of life is the primary endpoint. So in that time, the difference might not be as huge as the difference when those other primary endpoints were utilized, and maybe it's more like the difference between those two guys. So just to show an example of that, this is a patient that was also referred to us because of this non-healing ulcer, and that was her primary problem. We decided to do angioplasty. We had a nice result after the procedure, and then after 6 months after the original procedure, the patient came to us for a clinical follow-up, and the lesion was almost completely healed. So we were able to fix the patient's primary problem with a very cheap technology. And I think regardless if the vessel was open or would still be open 1 year later, the patient's primary problem was fixed, and the patient was happy. So that's what is important. So that's the last reason to always keep angioplasty in mind is the new technology that will become available shortly here in the United States. It's the drug-eluting balloons, and talking about SFA, paclitaxel is the drug that has been studied so far. Paclitaxel is an anti-neoplastic drug that was first described for different types of cancer, including breast, ovarian cancer, lung cancer, and melanoma. And as an anti-neoplastic drug, paclitaxel acts in the end phase of the cell cycle. You can see it there, and therefore prevents cell proliferation and also induces cell death. And this is the way that the technology works. We have the balloon, and on top of the balloon surface, there is a gel-like substance mixed with the medication. And when that gel gets in contact with the blood, it gets swollen. And once the balloon is inflated, the gel is compressed against the wall, and the medication is delivered into the vessel wall and then start to act. So so far, we have a total of 4 completed randomized controlled trials comparing conventional balloon angioplasty and drug-eluting balloons. And those are the trials: Thunder, FEMPAC, Pacifier, and LEVAT. And the results that I'm showing is the percentage of patients that had a second procedure for target lesion revascularization. And we can see that for the drug-eluting balloon group, that amount of patients was much lower than compared with the plain old balloon angioplasty. I think it's a promising technology. I think we still need to have a longer follow-up, and of course we need to compare that technology with the technology that we still have available nowadays, especially stents and drug-eluting stents. But it's still, I think it's a promising technology, and let's see what the future has to show us. I'd like to thank again everybody, and again, happy birthday to angioplasty.
Thank you, Dr. Yamada. You definitely made a point on the value of angioplasty in distributed revascularization, no question about it.